What if the sadness you felt didn't lift after a bad day, but stayed for weeks, months, or years? What if your mind swung unpredictably from crushing despair to frantic energy and racing thoughts? This episode is about treatments for mood disorders, especially major depressive disorder, MDD, and bipolar disorder. They are medical conditions that impact how a person thinks, feels, sleeps, eats, and functions in daily life. And here's why this matters. They are among the leading causes of disability worldwide. According to global estimates, mood disorders affect millions, cutting across gender, age, culture, and socioeconomic status. Depression alone is estimated to impact over 280 million people worldwide, while bipolar disorder affects around 45 million. Yet despite this enormous burden, treatment is often delayed or never received at all. On average, individuals wait over a decade after symptom onset before receiving effective care. That's 10 years of suffering, struggling silently with distorted thoughts, unstable mood, and functional impairment. In some cases, symptoms are written off as laziness, a bad attitude, or just stress. In others, people are misdiagnosed or too ashamed to speak up. But why is this delay so dangerous? Because untreated mood disorders worsen over time. Depression can become more severe, more frequent, and harder to treat. Bipolar disorder can escalate to psychotic features, suicide risk, or loss of insight. The longer someone remains untreated, the more likely they are to experience academic or occupational failure, relationship breakdowns, comorbid substance use disorders, physical health problems like heart disease or chronic pain, and tragically, in too many cases, suicide. In fact, suicide is one of the top causes of death among people with mood disorders. According to the DSM-5 and epidemiological studies, up to 60% of people with major depression have suicidal thoughts, and 15% eventually die by suicide if untreated. For those with bipolar disorder, the suicide rate is even higher. But here's the critical message we must start with. Mood disorders are treatable. From psychological therapies like cognitive behavioral therapy and interpersonal therapy, to biological treatments like antidepressants, mood stabilizers, and even cutting-edge neuromodulation, a range of effective options exists. Many people not only recover but go on to live full, meaningful lives once they get the right help. Let's begin by understanding what help looks like and how it heals. Section 2. Psychological treatments for mood disorders. Mood disorders like major depressive disorder, MDD, and bipolar disorder are not only treatable but have several well-established psychological therapies that have demonstrated consistent effectiveness across clinical trials. These therapies typically share common features. They are brief, often lasting about 12 to 16 weekly sessions, and focused on the present. Despite differing theoretical foundations, they aim to reduce current symptoms and prevent future relapses. 1. Interpersonal Psychotherapy, IPT. One of the most evidence-based treatments for depression is interpersonal psychotherapy, IPT, which is built on the idea that depression is strongly linked to interpersonal difficulties. Originally developed by Clarman and Weissman, IPT helps individuals explore specific interpersonal areas such as role transitions like job changes, divorce, becoming a parent, interpersonal disputes like conflict with partners or co-workers, grief like the loss of a loved one, interpersonal deficits or isolation. The therapist works collaboratively with the patient to identify which of these issues are most relevant, explore the associated emotions, and develop practical solutions. Techniques include emotional expression, improving communication, and problem-solving. Clinical trials consistently show that IPT is more effective than placebo or treatment as usual, and it performs on par with cognitive therapy, CT, in reducing depressive symptoms. Furthermore, IPT has been shown to prevent relapse when maintained after symptom remission. A large-scale implementation study in the U.S. Department of Veterans Affairs demonstrated that therapists trained in IPT achieved significant reductions in client depression, confirming IPT's applicability beyond research settings. 2. Cognitive therapy, CT. Developed by Aaron Beck, cognitive therapy is grounded in the theory that negative automatic thoughts and distorted cognitive patterns contribute to and maintain depression. The goal of CT is cognitive restructuring, teaching clients to recognize, question, and change maladaptive beliefs. A typical CT process includes educating the client on the connection between thoughts, emotions, and behaviors, using daily thought records to identify recurring negative thoughts, actively challenging those thoughts by examining evidence for and against them, practicing more balanced and realistic interpretations of events. For example, if someone thinks I'm worthless because I lost my job, the therapist would guide the person to reflect on their accomplishments and relationships to challenge that belief. CT is well supported by more than 100 randomized controlled trials. It's equally effective as antidepressants, particularly for moderate to severe depression, and offers an added benefit: protection against relapse. Follow-up studies show that skills learned during CT persist after therapy ends, reducing the likelihood of recurrence. There's also strong evidence supporting internet-based CT, especially when paired with periodic clinician support. This opens access to therapy for many who face geographic, financial, or mobility barriers. 3. Mindfulness-Based Cognitive Therapy, MBCT. A modern adaptation of CT, MBCT targets individuals who have recovered from previous depressive episodes but remain vulnerable to relapse. MBCT combines cognitive restructuring with mindfulness training, teaching clients to observe thoughts as mental events rather than absolute truths. Rather than fighting negative thoughts, MBCT promotes a decentered perspective, encouraging individuals to respond with non-judgmental awareness. Techniques include meditation, breathing exercises, attention training. Research shows that MBCT is particularly effective for people with 3 or more depressive episodes, especially when there is a history of childhood trauma. In such cases, MBCT may be as effective as continued antidepressant use in preventing relapse. However, MBCT appears less beneficial for individuals without these risk factors. 4. Behavioral Activation Therapy, BA. BA is rooted in the behavioral model of depression, which views depressive symptoms as stemming from a lack of positive reinforcement in one's environment. This can be due to life stressors like poverty, job loss, reduced social support, withdrawal from rewarding activities. BA therapy helps clients break the cycle of avoidance by scheduling meaningful and enjoyable activities, such as social outings or exercise. The idea is to restore a sense of accomplishment and pleasure, which can naturally elevate mood. Interestingly, research shows that BA alone is as effective as full cognitive therapy, and it is less expensive to deliver. It has also proven successful across diverse populations and in group therapy settings. These findings challenge the assumption that cognitive change must come before mood improvement. Sometimes behavior leads the way. 5. Behavioral Couples Therapy, BCT. Depression often intersects with relationship problems, particularly marital distress. In BCT, therapists work with both partners to improve communication skills, increase positive interactions, resolve conflict constructively. Studies show that BCT is as effective as CT or antidepressant medication for treating depression, especially when the depression is tied to relationship strain. In addition to reducing depressive symptoms, BCT often leads to improved relationship satisfaction, a dual benefit not seen in individual therapy. These psychological treatments reflect a multifaceted and flexible approach to managing depression. Therapists may choose a particular therapy based on the client's presenting issues, like grief, negative thinking, marital problems, treatment preferences, clinical judgment, and training. For example, someone who recently lost a job and feels isolated might benefit most from IPT, while someone with deeply ingrained negative self-beliefs may respond better to CT. If there's high avoidance or inactivity, BA may be the most immediate intervention. These therapies are not mutually exclusive. A client might begin with BA to re-engage with life, and later move into CT to address cognitive patterns. Or a therapist might integrate elements from different approaches based on evolving needs.